There are a million different things. But the second is what to do if you're on here and you're not a PSEDS provider, you're not part of one of these clinics, but clearly the data suggests you are going to be seeing our patients. So what should you do? So the first thing that I would just lift up that I think has been lifted up so much, it's hard to imagine there's anyone in this state not doing SBIRT, but I would recommend universal screening. And I'm recommending that echoing the words of every society known to man. We should be doing universal screening of all patients, bare minimum at the intake prenatal visit. Really, the recommendation is based on risk and change in social conditions that you screen multiple times during pregnancy. And I think in South Carolina, have done a very good job of doing SBIRT at least twice, but recommend SBIRT. If you can get this mechanized in your EMR, I'm showing an example in our system of where we do this and how we do the SBIRT. The actual tool you use for that S part, the screening part, matters not. There are a lot of really good tools. The best tool is the one that your team is most comfortable with. That's the truth. So could care less which one you use, but asking the questions in a non-judgmental way and in a way that creates a space where someone who is using could feel comfortable disclosing that use is really important. That's probably not at the check-in desk in the lobby. So SBIRT. I also recommend that all OBGYNs, midwives, PAs, NPs in this field who are able to make diagnoses of very complex hypertensive diagnoses and diabetic diagnoses, that if you can do White's classification for diabetes, you also have the aptitude to make the appropriate DSM-5 diagnosis of substance use disorder. The language that I have seen in charts leaves a lot to be desired. It would be as though we said that our patients had high blood sugar and that's all we made as a diagnosis. We did not say what the diagnosis was or what the pathophysiology was or how severe that diagnosis was. It would just be describing a symptom. They have high blood sugar or they have high blood pressure. We're more savvy than that. We have more training than that. And so I would recommend familiarizing yourself with the 11 different criteria in the DSM-5 for SUD. The diagnosis of any SUD is made when you have great or at least two of the items on that list in 12 months. And then severity is graded by how many of these you check off. Mild is 2 to 3, moderate 4 to 5, severe 6 or more. Again, I have 5 minutes, so we're going to move quickly, but I would recommend you can find this anywhere that you bookmark one of these and make at least try to make the diagnosis yourself appropriately. This comes from the Department of Health and Human Services in North Carolina in response to that extraordinary data about fentanyl-related deaths for pregnant people there. And really, I think the recommendations hold for all of us. I'll start at the bottom. Everyone should be getting screened multiple times, using a validated screening tool. As we prescribe opioids, we should be checking the database. And then for folks with a history of SUD or overdose, we should be doing these things. We should absolutely be offering Narcan at every appointment. If you have someone in a peer support capacity or a community partner there, they can actually distribute the Narcan. You should follow the guidelines for SUD screenings throughout pregnancy and the postpartum period. You should absolutely know the community resources in your space. You should know who is prescribing bupe. You should have a backline number to get your pregnant patients in. That referral pathway should be smooth, absolutely smooth. That is not, I'm typing in a referral in Epic and letting it go. That's, I'm picking up a phone and I know when that patient has an appointment. So those are kind of the basic, I think, ethical guidelines for those of us in the space that would be a minimum of what we should be doing. Marcella Smid had a very compelling editorial in April's Green Journal, April 2023, that really says that those of us who are trained as OBGYNs have a moral responsibility to save lives. And part of doing that is us becoming comfortable prescribing medication for opioid use disorder. I find this very compelling. In the SAMHSA databases, there are these wonderful tip sheets, and I have pulled out for you tip 63, which is the treatment protocols around opioid use disorders. Again, we won't have time to go through all of those today, but the key pieces that we should be doing in multimodal therapy is absolutely initiation of medication for opioid use disorder. We'll talk about some of those. cognitive behavioral therapy, treating comorbid diagnoses like depression and trauma, addressing their social determinants of health, and then making sure, if possible, you get them in a controlled environment. Serenity Place is a wonderful example of a controlled environment. Intensive outpatient therapy can be a controlled environment. Unfortunately, the prison system is also a controlled environment. It's not the one we want to see our patients in, but we do provide care there as well. Again, the most important thing if you are arranging outpatient therapy is that you have that appointment made for someone before they leave their office. If you think putting an order in Epic and then letting them go is making that appointment, it is not. And the likelihood of success on that interaction is extremely low. So highly recommend that you and your office bear the burden of the system of making that appointment. Just kind of walking through the medications for opioid use disorder treatment. Again, this is a little bit beyond what we can do today, but both methadone and buprenorphine are recommended as first-line meds by ACOG, SMFM, and ASAM. Methadone, of course, is a full agonist at the opioid mu receptor. It's administered daily, usually daily, at the federally accredited clinics. It's associated with a high treatment retention, but usually requires daily observed dosing, and it can prolong the QT interval. So if you have somebody with QT syndrome, that's not a great med. It can be preferred for patients with very severe OUD, folks with IV drug use, and those who really need the structured care of daily intervention. Let me move over. Naltrexone is one that we do not start in pregnancy. It is an antagonist at the opioid mu receptor. Someone needs to be completely withdrawn before dosing. If someone comes in and has been stable on naltrexone prior to pregnancy, you certainly can continue it, but we would not recommend medication start during pregnancy with that. And then finally, buprenorphine, which is the most common that we are currently seeing in our patient population, is a partial agonist at the mu receptor. It's available by prescription. We can do home dosing, less frequent clinic visits, so people can work. They can parent their kids. They don't have to show up someplace at 5 a.m. It is associated with improved neonatal outcomes. We'll go through that. Less severe and shorter neonatal opioid withdrawal syndrome, more favorable birth weights and gestational age outcomes, maybe lower retention into care, and no improvement in maternal outcomes. So equal to methadone from a maternal standpoint of measurable clinical outcomes, improved outcomes for kiddos. Again, more than we can go through. You can see the intrinsic activity at the mu receptor for each of those medications. And then just a few pieces of critical data from the literature. This study from Suarez, really important nested cohort study, 2000 to 2018. They looked at 2 million births, 11,000 that were exposed to buprenorphine, 5,000 to methadone, and they found statistically significant lower NAS levels for those exposed to bup, lower NICU admission rates, lower preterm birth rates, low birth weight rates, and lower cesarean delivery rates in the bup group, but the same rate of severe maternal complications, about 3%. This was really a landmark study. Dr. Andre Jones from Chapel Hill. They had 131 neonates whose mothers were followed to the end of pregnancy. According to treatment group, they had 58 exposed to bup, 73 exposed to methadone. The bup group required significantly less morphine after birth, had shorter length of hospital stay, and shorter duration of treatment for neonatal abstinence syndrome. So the neonatologists frequently prefer this. And then finally, just because it was recently published in the past year, a systematic review on naltrexone really showed same gestational age of delivery, significantly lower NAS, but no RCTs available in the literature. Harm reduction, this is what Narcan looks like. My 18-year-old I just took to college asked if she could have a Narcan in her bag, which both broke my heart and I thought to be a socially responsible ask to go to college. Very easy to administer. Those are the instructions there. And then fentanyl test strips we hand out in our office. Interesting for those of us who've been doing COVID home testing, and an important thing to know, a double line is negative, a single line is positive. So it's counter to your experience with COVID tests. So as you're counseling, most folks now have done COVID home test, and it's important to tell them what positive and negative are. Final thing is just around the experience of stigma. There are tools to measure stigma for folks with substance use disorder. Dr. Ali Kimura did some research on this, looking at this particular tool. This is specific to healthcare as well for folks with substance use disorder, and really measured very high anticipated stigma levels in folks receiving care in the Magdalene Clinic. There is a framework that's important for us who take care of any human, really, but certainly humans who have been traumatized. The ALLY framework, avoiding assumptions, learning about the whole patient, listening to the patient, and very important, yielding to the patient. So this is my final slide, lessons we've learned over the years of taking care of folks in the Magdalene Clinic and just taking care of humans on planet Earth. Pay close attention to what's killing our patients. The presumption around hemorrhage, hypertension, and infection is no longer true. Commit to universal screening. Know how to make the initial diagnosis. I recommend every one of us establish very clear and highly effective referral pathways ASAP. You shouldn't have to reinvent the wheel every time you see a patient with this disorder. If the lag to treatment is greater than 7 days, I do recommend that you prescribe buprenorphine, and you can use this resource to do that. And finally, trauma-informed care for every single one of us who are patients or employees in the office.